white plate. I'm here to whoop ass. Whoop ass. No time for lunch break. I'm the one who brings you.
Good morning, everybody. Dr. Vasquez here, coming to you live to talk about clinical nutrition, and today I'm going to talk about a little bit of metabolism. So yesterday I posted a video talking about vitamin B1, also known as thiamine, and so today I'm going to talk about vitamin B2. But before I talk about that, I'm going to talk a little bit about this whole thing of metabolism for those of you who are not familiar with the concepts. So as I start to write this out, metabolism, a lot of people talk about metabolism. This is just kind of an introduction for people who maybe need the introduction. But metabolism is basically the totality of a bunch of biochemical and enzymatic processes. Oops, I don't know why that disappeared. So metabolism is basically everything that your body is busy doing. Some people, talk about having a fast metabolism or slow metabolism. So you can think of that as representing the speed or efficiency of those reactions versus the lack of that speed. And the classic example of that is hypothyroidism. So thyroid hormone controls the speed of a lot of different reactions, and that's why when people have hypothyroidism, everything tends to slow down. And when people are hyperthyroid, or they have too much thyroid hormone, things are a little bit too fast, and people can have a fast heart rate, or they can feel like they're too hot. So again, when we talk about metabolism, we're talking about the sum total of all these enzymatic processes. But to grasp that, you would then have to understand, of course, what is an enzyme and what do enzymes do. So enzymes are globular proteins, and basically they change things. So a globular proteins can have different three-dimensional structures. Sometimes they're long strands, kind of like a chain of amino acids. Sometimes that's the case, like with peptide hormones, for example, they can be kind of linear. Some proteins or peptides are just maybe three different amino acids together. And the best example, of course, is glutathione. Glutathione is an antioxidant, and it's three amino acids together. It's not really a true protein, so to speak. It's called a peptide, which is just a collection of a few amino acids, whereas a real protein would be, could be hundreds of amino acids. And the three-dimensional shape is usually kind of globular, especially of enzymes, and channels and receptors. They tend to have, again, what's called a globular form, so it just looks like a ball of amino acids, and that's what a protein is. But specific to enzymes, enzymes are globular proteins that change things, or they do something. If it's an energetically downhill reaction, then it just does its job and facilitates the change from one situation to another, and I'll explain that in just a moment. If it's energetically uphill, or something that requires energy, then that protein will have to typically destroy or dissolve a molecule of ATP in the process. So ATP gets in there and blows the thing open or changes the shape, and that's how this enzyme can work energetically uphill against resistance. It has to be fueled by something, and that would usually be ATP, which comes, of course, from the mitochondria. So enzymes, I'll just try to keep going with this idea. Enzymes just change things. And that's part of this big phrase called, or big term called metabolism. And I'll give you a few examples of what gets changed. Sometimes we change the chemistry, and a good example of that is fatty acid metabolism. So for example, like I did this morning, if I eat a muffin that has flaxseed in it, and that flaxseed contains omega-3 fatty acids, and my body wants to convert those omega-3 fatty acids into longer chain omega-3 fatty acids. So let's say that I eat a flaxseed muffin that contains an omega-3 fatty acid that looks like this, but my body wants to end up with a longer chain, maybe that looks like this. So the body would then have to add additional carbon fragments onto this, and that requires energy, and it's a chemical process. So through elongation and desaturation, the body could add more carbon chains onto this fatty acid from flax oil and turn it into EPA or DHA. That's a little bit theoretical, but it's a reasonable conversation. So again, enzymes change things. They can either change the chemistry or they can change, let's say, the location. An example of that are the many pumps that we have on the cellular surface. So I'm looking around for a model. I don't know what to use for a model, but I guess I'll use this since it happens. This is a Kleenex box. So let's say this is a cell or a tissue or an organ like the liver or something like that. And within the cell, your body wants to pump things in or pump things out. So your body can use a pump on the cell surface and pump these things out it could be an amino acid, it could be something like bile, it could be cholesterol, it could be a neurotransmitter like glutamate. If your cell has too much glutamate or too much potassium or too much calcium or too much sodium, it has to pump that out. So it uses an enzyme, usually that requires ATP, and it pumps the stuff out. That was a pretty good model. And that's a very energetically expensive process. So your body spends a lot of energy just pumping things in and out. Just pumping sodium and potassium in some tissues requires 50% of the entire metabolic totality of that tissue, like in the brain, for example. So you think of your brain as thinking and memorizing and whatever, or getting pissed off. But your brain actually spends half of its energy just pumping in sodium and potassium. Pumping in potassium and pumping out sodium. That's half of what your brain is doing all day long. So again, enzymes change things. They could change the chemistry. I'll give you an example. Like changing fatty acids. It can change the location of things like enzymatic pumps, and you've got tons of pumps. You can pump in and out neurotransmitters and ions. That gets a lot of traffic. I mean, that's pumping in and out amino acids, pumping in and out other fuel sources. Sometimes it's a passive process, and sometimes it's an active process, and sometimes it can be both. So sometimes your body has like a passive channel for something, and as a backup or during stressful events, your body will have an active process that requires ATP, but at least it gets the job done. So you've got pumps. That's, of course, most of it right there. Let's see, I'm just trying to think of any other example. Those categories may be so general that it covers everything. Let's see, chemistry. Yeah, that's probably sufficient. So in order to maintain so-called homeostasis, which is of course never homeostasis, it's homeodynamics, because your body is always either fighting uphill or fighting downhill or trying to repair something. So all of those processes take energy, and the processes themselves are facilitated with enzymes, and sometimes those either do or do not require additional energy, but that's the whole sum total of metabolism. So having said that, that was kind of a little bit of introduction that could have been discussed yesterday, but now I just added it right now. So right now I'm going to talk about riboflavin or vitamin B2. So vitamin B2 is just another vitamin in the group of so-called B vitamins, either called B2 or riboflavin. So you get a few milligrams of this in your food, unless you're eating, a bunch of processed junk, then you're probably getting less. Let's see. Oh, let me go back slightly. Let's see if I want to do this now or later. I think I'll do it now and later. So I wanted to add a quiz question, which apparently I'm doing right now, just for kind of like trivia in a sense. And I'll give you the question right now, and then I'll give you the answer later in the same video. But here's today's pop quiz. So we're going to do a pop quiz. And maybe I'll even list out the options to make it a multiple choice, but we'll see. So the question is, What is the fastest nutritional deficiency to develop? And that's the question. So let me rephrase the question. Let's say you take a normal person with normal nutritional status. What nutrients are most likely to become deficient within days? So, for example, and this is a common argument within medicine, among medical doctors, for example, who don't know about nutrition, and they think, oh, well, nutritional deficiencies they don't really happen, or they don't happen to Americans because we're all fed such a great diet. And I'll give you a clear example of that. One of the arguments against either testing or treating vitamin B12 deficiency is, oh, well, you have a reserve in your liver of at least 6 months. I've heard that argument from attending physicians in hospitals, for example. They say, oh, well, this person can't be deficient because they have a reserve of B12 in their liver of 6 months. They can't be deficient today. Well, what if their deficiency process started 8 months ago and they had a reserve of 6 months, like you said, and now they're deficient? I mean, it's a ridiculous way to avoid having to think about it, but I have heard that argument from one of my attending physicians when I was in hospital residency. She said, oh, well, this patient can't be deficient. She's not anemic. That was stupid. Anyway, question for you right now is, what are some of the fastest nutritional deficiencies to develop? And even as I ask the question, I can come up with a couple different answers. But I had originally thought of 2 answers to this question, but now I think it should reasonably have probably 4 answers. So again, we're starting with a normal person, and then we're going to make them nutritionally deficient within a matter of days. What are the nutrients that are most susceptible to being depleted within hours and days? So, yeah, that's a reasonable question, and I've got reasonable answers, and so we'll talk about that. I'll give you the answers later at the end of this video. And maybe I'll come back and revisit that as we go through, just to kind of prompt you to think about it. So anyway, let's go back to talk about riboflavin. Just like thiamine or vitamin B1, and just like all B vitamins for the most part, and just like magnesium, riboflavin could be involved in hundreds of different metabolic processes. So again, let's see. As I kind of mentioned yesterday, enzymes commonly, almost always, require either a cofactor, which would be like magnesium, for example, or it could be selenium, or they require a coenzyme, which is typically a B vitamin. So in order for this globular protein to do its job, it usually needs let's just say it needs a lubricant, or it needs a little bit of help to work better. And that could be a cofactor like magnesium, or it could be a coenzyme like riboflavin. Let's say that this globular protein kind of has a hinge on it, as they commonly do, even though it's a molecular hinge. And in order for that hinge to work better, let's say we have to lubricate it with cofactors, which are minerals like magnesium and selenium or zinc, or a coenzyme, which is typically a vitamin. It could be zinc, it could be molybdenum, whatever. So that's why vitamins are important, is because let's assume a person is sufficient in protein and they can make the enzyme, but if they don't have the cofactor to make it work better, it's just not going to function at the speed required for optimal health. And that's why you see so many people who are kind of okay healthy, but they feel crappy, they feel slow, they feel fatigue, depression, whatever. And that'll take us into talking about riboflavin. So riboflavin, of course, functions as a coenzyme for many different enzymes, any one of which could be defective, and therefore any one of which, if the enzyme is defective, then that process, whatever it's supposed to be doing, isn't going to advance. And so if a person, let's say, is born with a genetic defect, or let's say they're exposed to a pesticide because their government has been overtaken by chemical companies and now all the food has pesticides in it, and these enzymes now don't work very well because they're jammed up with pesticides, one of the ways to get that defective enzyme to work better is to give it more vitamins to help kind of lubricate that function. And so that's part of the rationale for using nutritional supplementation, either when people have known genetic defects or suspected genetic defects, or they just live in a poisoned world where all their enzymes are a little bit gummed up because of all the pesticides and the glyphosate and heavy metals and all this junk that's in our medical system and food system. So the best article on that topic was written by Bruce Ames in the American Journal of Clinical Nutrition. And the title of it is something like high-dose vitamin therapy stimulates variant enzymes by addressing their kind of attraction constant or reaction constant. So every enzyme should have more or less a speed at which it functions. When people have genetic defects, the enzyme just doesn't work as well. It's too slow, let's say. And so in this brilliant landmark paper by Bruce Ames, he says that one of the ways to get the enzyme to work better, whether it's genetically defective or potentially even defective through pesticide exposure or chemical exposure, is to use high-dose vitamin therapy to lubricate that enzyme to make it work better. I've actually never used that analogy of lubrication, but it's pretty damn good. So anyway, let's go back one more time to riboflavin. Riboflavin facilitates a lot of different enzymes, the most famous of which is glutathione reductase. So glutathione is an antioxidant. When it gets oxidized, it has to then be regenerated or reduced back to its potent form to again function as an antioxidant. So again, glutathione is an antioxidant. When it gets oxidized, we have to reduce it back to its beneficial form, and that occurs here with an enzyme called glutathione reductase. Glutathione reductase starts with an R, just like riboflavin starts with an R, and that's how you can remember that glutathione reductase requires riboflavin. This is also a common laboratory test for measuring riboflavin status, is glutathione reductase. So this is important physiologically, and it's also important, it's also important from a laboratory, I don't know why this thing bounces around. It's also important for from a laboratory standpoint because you can measure the activity of glutathione reductase and thereby assess someone's riboflavin status. So I talked about laboratory testing yesterday, the good and the bad of it, a little bit conceptually. You can do that test if you want. I've seen plenty of them. I've never personally ordered that test, but I've received lots of copies of lab tests that have that in it. And also looking at glutathione levels, which, if you're going to measure glutathione reductase, you might as well look at a serum or a plasma glutathione as well, just to get a more complete picture. But you can look at a lot of other things too. Anyway, those are available lab tests. How would you know that someone is... So that's the physiology and the laboratory analysis of it, in addition to looking at other things. The thing is, we collectively would have to distinguish between looking for deficiency, which is quantitative, or looking for defective function, which is more of a qualitative issue. But that would vary based on what we're looking for. So again, let's assume that riboflavin functions in hundreds of different enzymes and different processes, any one of which could be defective, any one of which could lead to a clinical syndrome. We would then have to target in on what we're actually looking for. So again, a person could have a normal level of riboflavin in their blood, their glutathione reductase level could be normal, and they could still need more riboflavin because they have a defect in a different pathway. Let's see. Since I mentioned a little bit about function, I'll mention one more item here, and that is riboflavin is also necessary for mitochondrial function, especially in the electron transport chain. But remember what I said yesterday. Before anything can even get into the mitochondria, it has to go through the pyruvate dehydrogenase complex or the pyruvate dehydrogenase shuttle. And if you saw yesterday's video, then you would already know how to make that work because I told you about 1, 2, 3, 4, 5 cofactors, and I told you how to overcome the inhibition or to promote disinhibition of that pathway. So if you saw yesterday's video, then you should already know this perfectly. And you also know that one of those cofactors is vitamin B2. So that's another example of so-called metabolism. In order for your mitochondria to work, the fuels, most of the fuels, have to go through the the carbohydrate fuels anyway, like sugar fuels. They have to go through the pyruvate dehydrogenase complex, and that requires riboflavin. And so that's a really good example of, if you understand that, then you have a good way of understanding and therefore explaining the role of vitamins in so-called metabolism, which is a huge generalized concept. So what are the deficiency symptoms of riboflavin deficiency? First of all, it's quite common. I think somewhere between 6 and maybe 40% of the population. Because remember what I said previously, your body is not designed to hoard nutrients, and your diet isn't so-called designed to give you a ton of nutrients. It's designed for your minimal survival. And if we are all mostly in what's called marginal nutritional status, if we're not taking supplements, then any illness or stress or exposure to caffeine, alcohol, pesticides could make us deficient again. And that's the reason that I have always promoted vitamin supplementation. So back in 2004, 2005, and again in 2011, and of course in my books, I've described what I call the supplemented Paleo-Mediterranean diet, which is a Paleo-Mediterranean diet along with nutritional supplementation. And so the reason is to avoid marginal nutritional status and promote optimal function by promoting optimal enzymatic and physiologic function. So obviously, like, I've published that like 3 or 4 times. Well, yeah. So you can look at that conversation in those articles. I'll post them on the website. They're already on the website, but I'll post it again. Let's see what I want to say about this. Oh, deficiency of B2. The obvious, let's see. What's the most obvious? What's the first deficiency symptom of any nutritional deficiency? Most nutrient deficiencies have the same clinical presentation across the board. I've talked about this before. I mentioned it once before, so I'll let you think about it for a minute. All nutritional deficiencies start with the same deficiency symptoms. As the deficiency progresses, then we start to see a difference here or a difference there. The unique difference that we see, so you should still answer question number 1, but I'll give you time to think about it. So as the deficiency progresses, then we start to see unique patterns that are more specific to a nutrient deficiency. And the classic manifestation of vitamin B2 deficiency is called angular stomatitis. Sometimes called angular cheilitis. I don't like that word because I don't even know what it means. But a better term that actually is logical is angular stomatitis. So angular just means corner, and stomatitis means inflammation of the mouth, and that's exactly what it is. So, and you can see this every once in a while. I used to see it in one of our neighbors when we lived in Spain. We lived in a small little village that was actually founded by the Romans, or at least at one point was taken over by the Romans. And one of our neighbors had really bad teeth, and they just had poor health. The whole family was just a mess. But anyway, this guy had angular stomatitis, and the corners of his mouth were always irritated and inflamed, and he eventually lost his teeth, and it was just a mess. But, and of course he wouldn't take any advice when I told him he needs vitamins. But he had angular stomatitis. So it typically starts here in the corner of the mouth. And again, it's the corner, that's why it's called angular. And stoma is opening, or in this case the mouth. And it's inflammation in the corner of an opening, which is right here in the corner of the mouth. And that's again called angular stomatitis. And that's a classic, not necessarily pathognomonic, but it is classic for B2 riboflavin deficiency. After that, the third most common manifestation of riboflavin deficiency is related to the first manifestation, because things just get worse. If you have this and it gets worse with time, then you get this. So again, I'll give you another moment to think about that. So I'll call out number 1, number 2, leading to number 3, especially in women. And then what would we say? I guess we could talk about number 4, which could also be seen as an extension of 1, 2, and 3. It's just now things are getting worse again. So now things are getting worse, and it's a stepwise progression. These are the ways I would think about it. I mean, you could find this could also progress. So the angular stomatitis could also progress. So it typically starts in the corners of the mouth, but it could later involve like the whole mouth and the tongue and all this kind of stuff. So I'll go ahead and give you, I think this is pretty much all I want to say about this. And then we'll talk about how to treat this. So you could do lab tests to diagnose it, and then you could treat it, or you could be like me and just treat it. So again, if the normal diet is only, with most B vitamins, it's 1 to 2 milligrams, let's say. What's the therapeutic dose or treatment dose of riboflavin? And obviously you have a range there, but you should know what the range is in order to be safe and effective. If you go too high, it could be dangerous theoretically. If you go too low, then it's not going to work, but you think you did something and then the patient doesn't respond, and then you don't know if you did it right or not. So I tend to go high dose therapeutic intervention, which therefore also serves as a therapeutic trial. So, I mean, that's the real art of clinical medicine. Isn't doing damn lab tests all the time necessarily, even though, of course, I love lab tests. I've taught the topic, and I do them. But you can't do a lab test for every damn suspicion and idea that you have. You have to take action. Like I said yesterday, and like I've said for many, many years, decades by now, no patient ever got better from getting a lab test. Patients only get better from interventions. And so if you can intervene and use your intervention as a source of information gathering, then that functions as a test. It's called a diagnostic trial. So if you suspect that someone's B2 deficient and you implement the appropriate diagnostic trial, which is also your therapeutic trial, and you see whether or not they respond, then that gives you sometimes the answer that you're looking for. Let me go back and just say one more thing about lab tests. So I did, like, a standard recognized specific lab test for riboflavin deficiency is measuring the activity level of glutathione reductase. In some patients, you can also look at their homocysteine level. So homocysteine metabolism involves B2, B6, B12, folate, and also cysteine. You could also say, it's different, but you could also say betaine, you could also say methyl groups. I mean, some of these are transporting methyl groups, so that's how the whole thing works together. But you could measure a homocysteine level, but it's not specific to riboflavin. It is riboflavin, it's also pyridoxine, it's also cobalamin, it's also folates. It also gives you an idea of cysteine status, and it also gives you an idea of methane groups, which can be provided by betaine. So that's at least, legitimately, 6 or 7 different factors when you measure that one test. Okay, so now I'm getting